So just to introduce sort of what we're doing here really quickly, most of you I'm sure know that One Day Sooner's mission is to advocate for volunteers for human challenge trials. And more broadly, we're invested in medical research, in empowering research subjects, and making this a process that is thought of more as public service and as more of a sort of collective endeavor than it might be now. And of course, the other part of the mission is to develop a safe and effective vaccine quicker. All of these things are partly just because we live in the country and the society we live in, tied up in questions of race. So medical research has a long history of exploitation, a long history of problematic practices throughout the medical field and throughout the research field. And we acknowledge that any possibility, especially of conducting a challenge trial, is going to rely on informed consent. And the reason we have informed consent, even in the form that we have it now, is because of these exploitative practices that have happened historically. So we try to be as grounded as possible in that history and in considering that in every phase of vaccine development and in every phase of medical research. But again, as we live in this country, we all see the news, we all, again, live in this country. And so anything that happens has to be about race, and it has to be about gender and class and a lot of other intersectional phenomena. So we as an organization want to use our advocacy to make sure that we're thinking about these things equitably, and especially vaccination is one of the next things that's sort of staring us in the face. And we don't want that conversation to be the equity dimensions, the justice dimensions, the racial dimensions to be left out of that conversation. So for that reason, we've brought together several scholars with us to begin this conversation and to help us, help us start this conversation about what equity should look like in vaccination. I'll introduce them briefly, but we have two senior scholars here with us, and they've brought with them two emerging scholars who so hopefully will have perspectives that will really drive us towards the future and really help us think through what this field should look like and how the process of vaccination can push us forward to being a better, more equitable, more just society. So with that said, I'll go ahead and introduce the panelists, and then they'll each have about 10 minutes to discuss their perspective on vaccination, drawing on their own research and where they're coming from. And then the big question that I've posed to them that they'll explore is what are these questions about the future? So the question is, what can we do right now in the next months, the next year that this vaccine is being developed? What can we do right now to make the process more equitable, to start to incite change? But I also want to acknowledge that this is work that is going to be going on for years and decades, and hopefully not centuries, but that's kind of how we've gotten here. So I want us to be thinking, I hope we can think in long-term terms as well. So I've asked them to offer their thoughts on that short-term future as well as the long-term future. So with that said, Dr. Yolanda Wilson will be our first presenter. She is an assistant professor in philosophy at Howard University. She was a fellow at the National Humanities Center and an Encore Public Voices Fellow in the last year. And she is currently working on a monograph titled Black Death, Racial Justice Priority Setting and Care at the End of Life. And she's brought her colleague, Jovan McCalester, who is a lecturer at Howard University in political science. She's currently a research associate for the John and Eula May Cleveland Endowed Chair in the Afro-American Studies Department, and is an associate editor for A Life of the Mind, Essays in Honor of Andrew Billingsley. Ruqaijah Yearby is joining us from St. Louis University. Ruqaijah has degrees in law and public health and is now a professor at the Center for Health Law Studies at St. Louis University School of Law. She's also the director there of the Institute for Healing, Justice, and Equity. And among many projects that she's published and is working on, she's currently co-PI of the Robert Wood Johnson Foundation grant entitled, Are Cities and Counties Ready to Use Racial Equity Tools to Influence Policy? And she's brought with her Nia Sumter, who is a graduate student in the Department of Communication at St. Louis University. She received her BA there in African American Studies and Medical Humanities. And her experience as a sickle cell warrior has been the impetus for her academic interests that look at slavery, the birth of the US healthcare system, and the role of white supremacy in the delivery of healthcare. So with that, I will pass it on to Dr. Wilson, and we'll go from there.
So thank you so much for having me. I didn't realize I hadn't updated my bio. I'm actually an associate professor, so that's one thing that I've got to put on my list of things to do. So this is a really important conversation, and I enter it as someone with background in social and political philosophy, philosophy of race, and bioethics. And so when I think about questions around vaccine equity and race, I'm thinking about it through that lens. So a few weeks ago, I was quoted in Science News, and that article was around, again, ethics of vaccine development, and the focus of that article was Henrietta Lacks, right? And so the legacy of using her cells, which are known as HeLa cells, in all sorts of medical research, but including some forms of vaccine research. And the one thing that I said that I think is relevant for this conversation today is that it's important not to act as though the science that happens is divorced from the communities in which it happens, right? And I guess I would expand that even to say that it's important not to act as though the science that happens is divorced from the communities, not only the communities in which it happens, but the communities that are affected by what happens, either by being the beneficiaries of those findings or by being left out of the findings, right? And so I think that's going to be an important starting point for me. I want to think about this through 3 principles of bioethics that kind of guide my thinking about vaccine development and a lot of other issues. There are a few principles of bioethics. I'll focus on 3. One is autonomy, and I'm going to just set that aside for now because the way that bioethics traditionally think about autonomy is a little bit differently than how I think about it. But I want to start with the principle of non-maleficence, right? So that means the principle of not harming people, right? Or trying very hard not to harm people. We know that just the nature of medical research, of scientific research, sometimes there will be harm, sometimes there are risks, and that's unavoidable. But this idea of setting out to behave in such a way that you're not harming people is an important underlying principle of bioethics. And I would say that part of the issue around vaccine equity is that there is a long history in certain communities of being harmed by medical research and by medical practice, right? So violations of community trust, right? I mean, we know these large scale studies that become the textbook studies of ethics violations, such as the Tuskegee syphilis experiment, right? That happened from 1932 to 1972. But there are also, I think, kind of less understood or less appreciated are the ways that these smaller slights that happen, right? What happens when you go to the doctor? How are you treated by the physician, by the rest of the staff, even the person who's sitting at the front desk, right? What does a history or a lifetime of those kind of interactions add up to in terms of how one regards the medical system and medical practice, and how does that extend to willingness to participate in medical research, for example, right? And so I think that at the very least, medical research in the US, and I would say, I hate to say the medical industry because that's not quite the word that I want to use, but that there's a well-earned mistrust, right? There's this entire ecosystem of mistrust that goes from, you know, again, these more famous types of studies that, you know, become the textbook ethics violations to the kind of day-to-day interactions. And we've seen a lot of data coming out in recent years that the popular press has picked up on in terms of things like ignoring symptom complaints, right, or symptom reports. I don't like using the word complaints. Ignoring symptom reports, particularly around pain management in African American communities, right? What's been very large and that the popular press has picked up on in recent years is the maternal fetal mortality gap, the racial disparities there. And so, as I said, these kind of things become part and parcel of the ecosystem of how the medical system is perceived. So it's not enough to say, oh, trust this vaccine, it's safe. When you're entering communities and spaces who have been told that things are safe before, who have had symptoms ignored and been told, oh, that's all in your mind, or you're just drug seeking, right? Who've had these offensive, I would almost say gaslighty kind of interactions with the medical system in kind of individual ways, but also in these larger scale institutional practices, right? I mean, the Tuskegee syphilis experiment was funded by the National Public Health Service. So that would be, one thing that I'd set aside. The other principle that I want to think about, just opening the conversation, is beneficence. And that is the intent to do good, right? So that's a fundamental principle of bioethics, that in order to kind of ethically behave, whether it's in biomedical research or whether it's in these kind of clinical interactions, that the intention to do good, right, to make people's lives better, has to be kind of foundational it has to be the raison d'etre, right? It has to be why it is that we're gathering, why it is that we're doing the things that we do. But I would even extend this, particularly if we're thinking about racial equity and racial disparities, right? It's not enough to just intend to do good. And I think that sometimes, I've been in rooms and spaces where conversations around, why don't Black people trust us? I mean, we just have all these good intentions, right, come to the fore. And what I would say is, it's not enough to just intend to do good. You can't just show up and say, our hearts are in the right place, trust us. And, I think that there's been a lot of attention paid in recent years to, for instance, implicit bias tests. Like, oh, if we could just get rid of our implicit bias, then everybody will see that we're do-gooders, right? That somehow implicit bias becomes not only the starting point of the conversation, but also the ending point around making real changes, using real tools and the awareness that we have. I mean, we have at least 50 years of kind of modern scholarship on racial inequity and equity and justice, right? We have 200 years of just kind of broad Black scholarship thinking about these questions of race and equity in this country. And so, I would say at this point, it's almost willful to just rest on one's good intentions. And the third principle that underlies bioethics is justice, that I want to talk about. And often justice is framed as a kind of distributive justice model. And I think that is going to be incredibly important. And I think that's the crux of what we're talking about now when we think about equity and vaccine access, right? Distributive justice is who gets what, right? How do we decide to parcel out the benefits and also the burdens in society, right? And we want to make sure that is happening fairly. But what I would say is, one, we have to think about what our conception of fair looks like, right? And that has to be a conversation that can't just imagine abstract actors, right? That has to be a conversation that grapples with the historical reality of how folks have actually been treated. And then if you start from that starting point, then what justice requires is going to look different. But what I would also say that justice requires, even in bioethics, is a notion of restorative justice. In other words, fixing all the stuff that went wrong historically. And I think that, kind of circling back to the non-maleficence piece and the trust piece, we can't just, you can't just show up and say, trust me, right? There have to be real concrete things that happen. And at minimum, it was the 1990s before there was even an acknowledgement or kind of limp apology for Tuskegee, right? Given the hundreds of people who were impacted, not just the men who were the subjects, but think about their wives and other partners, their children were potentially exposed. And so, I think restorative justice has to be part of the conversation about justice. So just to kind of wrap up, because I know we just want to start with a little 10 minutes here and there. I think that, rethinking what these three principles of bioethics require is going to be important, right? I mean, you can't have a bioethics that takes race and racial injustice seriously without rethinking some of the fundamental principles of the discipline. And I'll just stop here. I know that we'll have conversation later.
Great, thank you so much. So Dr. McCalester, you can go ahead.
I will open, of course, by saying thank you so much for having me. I'm very interested in seeing how I can contribute to the conversation. In your bio that you were reading for Nia, she mentioned that she's a sickle cell warrior, I believe. I am a lupus survivor. And so when Dr. Wilson brought the opportunity to me, I knew that my own experiences with the medical community, but also my experiences in trials, because I do a number of them, one with NIH, et cetera, that, oh yeah, no, I make myself available because I understand what is at stake here, that I represent a number of different communities that are essential to the new development of drugs, testing, et cetera. So I understand the importance, of course, of research. But at the same token, as a political scientist, as someone who actually concentrates more so in Black political politics and concentrates more specifically with women, children, and things of that nature, I have to be cognizant of how we enter medical spaces, how we enter research spaces. So as a researcher, when I volunteer for a trial, I know what to do, I know what to look for, I know what questions to ask. And so I don't necessarily feel as vulnerable as I imagine other members of Black communities would feel. And so when we're looking at these types of challenge trials, we have to remember, as Dr. Wilson so wonderfully put, that there's history there. And so I enter the conversation where Black people with race, and race being this sort of the center thing, that they're not just, in terms of COVID, they're not contracting COVID because they're Black. They're not dying from COVID because they're Black, but there are factors that are contributing to 1 in every 1,500 Black people dying from COVID, correct? Right. But in that, there are so many structures and so many mindsets around that, that one puts them into positions where they're afraid to go to the doctor, because when they get there, someone won't necessarily believe the symptoms that they're telling them that they're having, or they might even be made to feel ashamed for the symptoms that they're having. They're feeling as though the information that they're receiving can't be trusted, because there's in our media at the moment, no one knows, quote unquote, who to trust. And so that distrust between the medical community, the distrust between Black people in the media, that distrust between Black people in research, because as Dr. Wilson says, we've been the subject of so many different botched research projects. All of that, I think, contributes to sort of being stuck between a rock and a hard place. Because even if we were to be able to educate various Black communities and saying to them, we're dying at high rates, we need to do these things, these challenge trials could actually be beneficial to us, we're stuck. We're stuck in the sense of, I could go and participate in this trial, but I remember my grandmother told me about Tuskegee. I could go to the doctor because I'm experiencing some symptoms, but I remember the last time my cousin went and she had a heart attack and they sent her home. And so there are all of these different experiences that they're having, the inability to sort of discern between who to trust in terms of media and information. All of those things are sort of coming to a head when we're thinking about this particular crisis. And so I'm sort of reminded of a personal story where I had a stroke, and I called the 911, and the operator didn't believe me. The EMTs came to my home, didn't believe me. I got to the ER attending doctor didn't believe me. And so by the time the tests were run and all of these things, a lot of damage had been done, all because the people that I met along the way did not believe me. And so these are the types of things where my background, my education allows for me to sort of bypass what I know to be the implicit bias of the people that I've come in contact with along the way, but to ask that of the average person, to ask that of the average Black person who has had the experiences very similar to mine, who have had the experiences that Dr. Wilson has outlined in their medical visits, who have had sort of the hearsay of what Tuskegee was really about. We know Tuskegee was about informed consent, but there are a lot of people in the Black community that think that they were actually given syphilis, and that it's almost impossible to convince some people in the Black community, especially older people, that that was not necessarily the case because of the level of distrust that they have for the medical community and for research, experiments. And so with all of those things in mind, I can imagine that we sit in these seats and we understand the implications of getting a vaccine, as quick as possible, possibly trying challenge trials in order to achieve that goal. But what we would have to contend with as people who, I like to say, speak truth to power, is that when we turn towards the communities that we represent, or the communities that, that have, how would you say, that have trust in us as scholars, it's hard to remove some of the stuff that's just true for them. And so I think some of the first things that we have to do is invest in authoritative voices. What do I mean by that? Members within the communities that we are trying to reach, right? And making sure they're the ones that are talking to various groups and from here to there. We also need to invest in making sure that the information is clear. I think it's hard for a lot of people, particularly in Black communities, where we know that medicine is a practice. We know that research is trial and error. But when multiple messages are coming, it's hard for a lot of people, American people in general, to sort of receive those messages. You told me to wear a mask not to wear a mask in March, and then you told me to wear a mask in April. And so for a lot of people, we understand why these recommendations change, but for the average person, that's just not something that they're just easily to digest, especially when there's issues dealing with trust. And the other part of that for me personally is, I think that the wavering message from lawmakers. As I sit back and I know, okay, I understand how federalism works. I understand the federal government is separate from the states, and the states are supposed to deal with the health issues of their residents. And I get that because of my background, but the average person doesn't necessarily know that that's kind of how our government works. They don't know that just because in Georgia something is happening one way, that it doesn't have to happen the same way in Alabama. And so having a clear, concise message from lawmakers, and lawmakers stepping up and making it clear that, from what I've read, at least 35 members of Congress are behind, or have been behind, using challenge trials to find a vaccine for COVID. And that's not necessarily information that is being widely shared. And so we've got to deal with the trust. We've got to deal with I won't say mixed messages, but the various messages coming out. And we have to deal with educating people on the realities of vaccines, the realities of the disease that we're dealing with, and the fact that if they don't participate, that our voices aren't heard and the data needed to help us isn't there.
That was great. Thank you so much. We'll move it along to Professor Yearby. Go ahead.
So I wanted to thank you for including myself and Naya on this. We're excited to go ahead and begin this discussion. Building on the work that has been done and discussed, I want to shift us to focus particularly on the problems that racial and ethnic minorities and the poor have experienced during the COVID-19 pandemic. I've co-authored a couple of articles with Professor Seema Mohapatra on this issue. And so my remarks are really going to focus on what has happened during COVID-19, particularly in how it has harmed and further eroded the trust in these communities, and that we really need to work at this moment to begin to build on sort of our goodwill. And so what I want to highlight highlight, just going back historically, because I think it's so important, as Dr. Wilson did, to ground it in sort of this history. When we look back at the pandemics, racial and ethnic minorities tend to be disproportionately infected and harmed, not because of any genetics, but because of structural barriers, structural discrimination, and lack of protections. Particularly during the 2009 H1N1 pandemic, we saw a lot of racial and ethnic minorities, Native Americans having a 4 times higher infection rate, Latinos and African Americans, because they were essential workers. And instead of receiving the PPEs, instead of being able to stay at home with paid sick leave, they had to continue to go to work. And we see this replicated during COVID-19, but I want to highlight one thing in particular, that during the 2009 H1N1 pandemic, Latino farm workers were disproportionately harmed. One, because they were blamed for bringing the disease to the US. And I'm going to talk about how we're doing that again during this pandemic. They lacked paid sick leave. They still lack paid sick leave now. So do the meat and poultry processing workers, healthcare workers. They lack access to healthcare, including vaccines and treatment. Their jobs increased their risk of respiratory illness because they were coming into contact with pesticides, making them more susceptible to H1N1, again, replicated in COVID-19. Their housing was crowded and often lacked basic amenities such as bathtubs, toilets, and they feared deportation and thus did not seek treatment. In 2019, we have not made the necessary changes, even though we have the data that these are some of the structural issues that people are facing. When we look at the public health response, it includes stay-at-home orders, socially distancing, but this ignores the reality of most racial and ethnic minorities, women, and the poor, who are the essential workers, who are forced to continue to go to work, to drive our buses, to process our food, to sell us groceries, to pack our mail, to deliver our mail, and they're not receiving the protection. This is already bad enough. But when you add on there the fact that several federal and state public health officials have begun to blame racial and ethnic minorities for racial disparities in COVID. And I'm just going to list a few just to highlight this particular point. We look at the governor of Florida, who blamed Latino farm workers for the rise in COVID-19 cases in Florida. The Secretary of Health and Human Services has allegedly blamed Latino immigrants for COVID-19 flare-ups. Numerous state and federal officials have blamed COVID-19 infections at meat processing plants on the behavior of workers. In fact, you can see in some of the worker protection guidelines that they talk specifically about the housing practices and the transportation practices of the workers, as if that was something that they have the power to change. If you're going to a rural area, you don't have the opportunity to ride a bus. If you're poor, you can't buy your own car. If you're a farm worker, they are housed oftentimes in housing provided by the farm owners. They're stuffed in, they don't have access to toilets and sinks. And in fact, an Ohio legislature and physician asked if the higher rates of COVID for African Americans was because culturally they did not believe in washing their hands as much as whites. And so when you listen to some of these statements by public health officials, and we move on to the discussion about COVID-19 vaccines and participation of these populations, it's not going to be an easy transition, right? We have to repair the things that we have done to harm this relationship. The discussions about lifestyle behavior, smoking, drinking, obesity, but not the discussion about requiring that workplaces provide social distancing, provide paid sick leave, provide protective gear. We often talk about how it's disproportionately hit Native American tribes, but we're not even sharing contact data with them, the state or the federal government. In fact, most of their data is coming from sometimes the New York Times tracking. And so when we think about moving to vaccines, in terms of some of the short-term fixes, I think it's very important, just picking up on sort of the discussion that was had, is that we need to partner with community groups. And let me be clear about what partnership means, because I know I've had people reach out to me who would like me to assist them in recruiting racial and ethnic minorities because I am Black. That is not partnering, that's tokenism. And so when I say partnering, we need to ensure that the partners who are racial and ethnic minorities are fully involved, and not only recruiting, but also developing what's going to happen in the trials, how the trials look, and be full partners in that. It also means that all the people involved in the vaccine trials, from the recruiters, need to undergo racial and equity training. Because if we don't understand the perspectives of the people that we're trying to enroll and continue throughout the process, the 1 to 2 year process, then you're going to perpetuate and continue the harm that we already have done, not only through COVID-19, but as was noted through Tuskegee and so many other studies. We need to stop blaming genetics and culture for racial and ethnic minority disparities. Because if that was the case, then we wouldn't need vaccine studies, right? But we have vaccine studies because there is a disease, and there's nothing in the color of my skin that is connected with that disease. And so when we talk about the vaccine, when we talk about treatment, then we really need to focus on what is the issue. When we enroll people into treatment, we need to ensure that we also provide equitable treatment, testing, and care for COVID-19. We cannot, and I've written about this in an article talking about involuntary consent, where we always go to poor people, people of color, women, and say, hey, enroll in our vaccine studies, but these are the same institutions that have blocked women, minorities, and low-income populations from accessing healthcare. And in this moment, particularly in COVID-19, these are probably some of the same institutions that have blocked treatment and testing. There's lots of stories about healthcare workers, Black healthcare workers, teachers being denied access to healthcare for COVID-19. I'll stop there because I think we can talk more about other things, but I think what we need to do is a long-term strategy where we acknowledge the harm that we have done, right? It's not just about Tuskegee, it's about the current moment of COVID-19. We have done so much harm, and we need to apologize and begin to work to rectifying that harm. Thank you.
Thank you so much. And it's Naya. I realize I've been mispronouncing your name. I'm very sorry. Naya, go ahead. And thank you so much, Professor Yearby, for your comments.
So as my fabulous panelists have already pointed out about the historical injustices that have happened from the medical community towards the Black community specifically, I think we should now kind of rotate the conversation and talk about the lack of transparency that is often missed in these kind of conversations about healthcare, and specifically looking at the Tuskegee study. Author Harriet Washington in Medical Apartheid even argues that the informed consent in the Belmont report that came out of the ad hoc trial would not, just justly kind of safeguard us from these research abuses, because the committee lacked a historian. So they end up answering or addressing the wrong ethical question. The pertinent issue was not whether the men had been duly informed of the experiment's danger, but that the men had never been informed that they were in the experiment at all. The men thought they were actually receiving treatment. And so much of that discussion is often lost on the committee when they started talking about what exactly was violated with this experiment, which principles were violated with this experiment. And so focusing, kind of refocusing on just medical abuses in general, we usually talk about these medical abuses within the scope of violation of respect for persons and benefice, but and hardly ever focus on the violation of the justice principle. And as my professor, and as Professor Yearby has been quoted in articles, saying that we need a revision to this justice principle and adding this human development approach, which requires researchers to provide a benefit to the population from which the research subjects originate from. And so kind of refocusing on my sickle cell experience, I see the need for this human development approach specifically because sickle cell has often been talked about within stigmatized and racialized terms of it being a Black disease, when we know that is very false, and people from Southern Europe countries often have sickle cell, and they often on the other end of the spectrum kind of experience discrimination because they present to healthcare institutions as a white person having sickle cell, and that kind of violates the whole norm of it being a Black disease. So when we move forward as a sickle cell community, as we move forward talking about research within our community, we have developed a slogan saying "Nothing for us without us," and so we challenge pharmaceutical companies when they have sickle cell people as an interest, that you have to include somebody from the sickle cell community, a leader, a patient, somebody who has a voice for the sickle cell community from the very beginning of these research protocols or design all the way into the implementation of these research designs. And so, yeah, I just really wanted to talk about those things. So as a minority who has to interact with healthcare on a very intimate level, I found a quote that highlights my experience kind of just perfectly, from George Bernard Shaw. He says, the tragedy of illness at present is that it delivers you helplessly into the hands of a profession which you deeply mistrust. So being a Black woman with a disease that is already stigmatized, I do not necessarily have the best experiences in healthcare, but I find myself kind of playing into the respectability politics of white supremacy and trying to wear university sweats or business casual and kind of trying to humanize my experience of pain to healthcare professionals to make them believe that I'm deserving of care. And so when you ask a community who's already had these experiences within healthcare to now participate in research, it's a little daunting, but we know the need is very real. So if we are to move forward in the conversation of what it looks like to perform clinical trials in the African American community, I think we should hear from scholars as well as the patient community and caregivers of those patients.
Thank you. Excuse me. Thank you so much for those comments. So the next thing I want to do is I want to give you guys an opportunity to ask each other any questions you might have. We do have some questions from the audience. I undoubtedly have some questions, but I wanted to give you guys, I know obviously some of you know each other, but some of you don't. So if you have any questions for each other, please go ahead.
I don't have questions, but I did want to jump in because I see some of the questions that people have. And it was just interesting for them asking, you know, traditionally women and people of color are underrepresented in medical research. And so how do we ensure that we can advocate equity in the research trials and for those undergoing it? So I think that's a great question. I always, but I'm going to leave that. I think it might even been to Dr. Wilson pose, but I just wanted to jump in one minute to say that as we're doing the research trials, I want to make sure that we do not further medicalize or connect race to genetics, right? And so part of the reasons why it's so important to have these communities participate is because those are the ones that are most impacted, that those are the people who are coming into contact with COVID. And so those are the best people you should have. And so to me, it's not just about sort of this social construct of race, of ensuring racial and ethnic minorities as if we're going to find some genetically different thing. It's ensuring that people from all communities who are impacted are actually participating so that they can receive the benefit. And so as I was talking to a reporter about this, right, it's people who work in communities like the meat packing and meat processing, because sometimes those environments are colder. And so COVID can live longer. So what a great population to ensure that it's effective vaccine for. The same thing for women, the same thing for just across the board. So I did want to just highlight that particular point and then leave it up to my other panelists to answer.
Okay, so I will jump in here. You know, I think that was kind of the last note that I left off on my remarks also, that I wanted to be very clear that when I think about race and vaccine trials, or vaccine equity, I'm not talking about biological essentialism, right? I mean, I think that sometimes we conflate thinking about race or thinking about racism as a kind of, there's just something fundamentally biologically different about Black people, whether it's Black people's genes or just some other, sorry, I'm adjusting my earpiece, or just some other feature of Black people that just makes us different and strange, right? So we want to be clear that what we're thinking about are these social determinants of health. That's kind of the fancy term for it, right? These factors in terms of where you live, what kind of job you have, how often you're able to stay inside, how often you have to go outside. You know, so one of my other interests, I haven't written on this, but I've gotten in some internet fights about is the idea of rural health, right? I'm from a rural area, and I remember the New York Times published this incredibly, I found it appalling, insensitive, disgusting interactive map, you know, essentially demonizing people from the South. Like, here's where the people didn't stop traveling after they knew that there was a pandemic. And, you know, and they set 5 miles for whatever reason. It wasn't clear why 5 miles was the metric, but here's where all the people were still going 5 miles, more than 5 miles in the pandemic. And I thought, you know, first of all, New York Times, if you're going to have people writing about rural people, then you need people who understand rural people. Like where I'm from, it's not uncommon to drive 5 miles to get to a grocery store. I mean, I'm from a town that literally has the only hospital for 20 miles. So even if you were experiencing COVID symptoms, right? The idea of you have to have a car because there's no public transportation, or you have to know somebody who will lend you their car or give you a ride or something, right? So these are the kind of things that we're talking about when we use the kind of fancy term social determinants of health. So my hometown actually ended up in the New York Times a couple of times. I was interviewed for some Albany related stuff, but Albany, Georgia. So if you Google it, it was a hot spot early on. And in fact, at one point it had the 3rd highest rate per capita in the world. So the per capita rate was much higher than New York, although New York was regarded as the epicenter of the disease. And I think that that's another way that we kind of miss what it looks like to be rural, what it looks like to be Black. Albany is regarded as this kind of poor Southern town. My mother was very offended by that characterization in the Washington Post, by the way, like 40 miles from the nearest interstate, but it is. I mean, that's what it is. And so, this was, it was right behind Wuhan, China, and Lombardy, Italy, in terms of its per capita infection rate. So I think, when we want to get these numbers, when we want to get this involvement, you have to have people involved on the research end, right? Not just the recruitment end, although the recruitment piece is really important, as Professor Yearby pointed out, but also on the research end, who understands what people are experiencing and why people are making choices that may look crazy to people who don't have that understanding. And this is, I find myself having this conversation lots of times in certain rooms, even around the mistrust thing. That's just, Black people are just paranoid. No. There's a long history here, and not just Tuskegee. I mean, you can go back to the antebellum period and see, Black women being experimented on. I want us to understand very clearly that a lot of medical schools that sprung up in the South sprung up around areas where they could take Black bodies and use them as cadavers, right? I mean, that's how even today much of our medical training happens on cadavers. And so, this is a long-standing history that lasts into these communities. So when you even talk about medical research, as Professor Yearby pointed out, right, a lot of times the very people you want to recruit are people who have had negative experiences with some of these larger research institutions, either because they're denied care as kind of regular patients, or the perception is that they're just being sent there to be experimented on, which is a very different perception than a lot of white communities have, right? A lot of white communities like, oh my God, it's so great that I live in North Carolina near Duke because I can go to Duke Hospital and get all this care and get this cutting edge research. I lived in North Carolina. I worked at Duke. I went to graduate school at UNC. A lot of Black people were very deeply mistrustful of Duke. And the thought was, oh my God, you're sending me to the Dukes. Right? That was regarded as the end, right? That's when they've given up on you. And like I said, I'm from Georgia. Emory had a very similar reputation. Oh my God, they're sending me over to Emory, right? That wasn't a yippee, we're getting cutting edge research. That was a, oh my God, what's going to happen to me? What are these people going to do to me? And so I think any kind of recruitment efforts have to, again, take seriously, not just the history, right? Because we can all learn facts and figures, but understanding how the history is still present. And how, in the absence of any kind of serious reckoning with the history, that, you're not going to get any kind of different perception of what medical research entails.
So Dr. Yolanda, you just made an excellent point, and I really do agree with everything you said, but I would like to challenge you, and when you mentioned the social determinants of health, to think about it in terms of the political determinants of health. So I read a really cool book this summer by Daniel E. Dawes. He wrote about the political determinants of health, and so as we think about the social determinants of health as housing, schooling, and these things, we really have to look at the political forces that inform our choices for, these systems. And so when we talk about it in terms of social determinants of health, is as if I had the actual choice in saying I wanted to live here when I've been relegated or redlined to this area where now I have to go to this school and participate in these things. So, and I see that political side really being kind of highlighted in my healthcare experience, because I kind of have the notion, kind of adverse to Dr. Joe Vine, when you talk about actually participating in kind of research clinical trials. I'm not there yet with my healthcare experience, just because we have a lot of policy work we have to move forward. And so in terms of sickle cell, it is important that I am very educated on my disease. But when we look at education, that, is congruent to high school education, kind of college degree education and things like that. So when I come from a high school that has an average ACT score of 18 and a very low college graduation rate, who's to say that I'm actually able to grasp the topics that my doctors need me to know and be informed about my disease if I already come from a disadvantaged background. And so healthcare just kind of perpetuate those already disparities in those areas of political determinants of health. So I agree with everything, but we do need an attitude and a policy shift before we really start to ask for African American or Black people engagement in these systems.
Yeah, I mean, absolutely. So when I use that term social determinants, it doesn't rule out like political systems that we operate in. That's technical language that perhaps I should have explained better. You know, one place that I really think about this, and that it's that it becomes writ large for us, is the first few years of Donald Trump's reign, and I'm calling it his reign very intentionally, right? You know, he saw it as his life mission to undo the little minimal healthcare reforms that happened under Barack Obama. And one place where this became interesting, right? Not just the repeal, right? The repeal itself was not that interesting to me, right? Given how entrenched some members of certain political parties are and can be. What was really interesting for me, and I think this is where some of the things you're talking about, Ms. Sumter, was the New York Times spent the first 2 years of Trump's reign finding these random Midwestern white people, and they would always have some image of them staring forlornly out the window. And essentially what the issue was is, I thought they were just going to cut stuff for Black people. I need Meals on Wheels. I need Medicare. I need Medicare. Like, I voted for Trump because I thought he was going to get these immigrants and these Black people under control. And now I'm finding that these social services that I use to stay alive are being threatened now. And what's been really interesting about that is not that the New York Times is centering white people staring out the window, but that some of these same white people then said, and I'm still going to vote for Donald Trump, right? That's a very interesting racial politic that has a direct impact, not just on Black people's health, but these are white people who are willing to die for the idea of whiteness. And that's fascinating to me. I can't imagine wanting to die just to be able to say that I'm white. But, you know, maybe whiteness is that special. I'm not white. I've never been white. Maybe my next life I'll experience it.
Absolutely. Absolutely. And yes, Naya, I completely understand and as I said before, the hesitation to want to participate. And again, I won't lie, they're annoyed with me because I sit there and I put the papers down and I read through the papers, and and I know that for me in my medical care, I've been treated differently because I come in there and they go, so you're a doctor. Okay. Oh, a political science. Okay. Well, here's some reading that I can give you so that you understand your treatment. And then when I come back and I say, whatever it is that I say, I'm respected in a way that I know that I would not be respected. Right. And so the example I gave you of it having the stroke, I was unable to say I'm a doctoral student. But by the time I was able to say so, I was accused of being drunk and high. And so I understand the idea that, it's not based biologically, of course, because race is not biological in that way. But I understand the idea that you can't have these conversations. And I hate to say it. I mean, you can have it with us, but we can't be the only ones in the room. I know that my perspective and my knowledge and my ability to sort of comprehend how these studies are being constructed is far greater than just the average person. I'm not even being specific about race at this point, right? And so I understand that, but I also understand that I and the rest of the panelists have a duty to sort of bridge that gap at times. And that gap might be bridged by literally talking to a relative. I had to convince an uncle to take his blood pressure medication, and he was insistent that they were going to do something to him if we took him to the hospital. And so having those sort of moments, that of course the impact is not very wide, but having those moments are necessary because you might represent that quote unquote authority, right? That can be trusted in a family member's life or can be trusted in a community. And so it's unfortunate, but I was just reading a doctor in France, I know that you guys have heard about this, was talking about using the BGB tuberculosis vaccine in Africa as a possible vaccine for COVID. And the quote, I had to write it down. The quote said something to the effect of, if I could be provocative, we should do the study in Africa where they have no face mask, no treatment, no ICU. Then goes on and says, we do it something like the AIDS studies where we use sex workers who basically were already engaging in risky behavior and they weren't trying to do anything to sort of stop the contraction of the virus. And so even as a scholar, in quotation marks, when I hear that, like, I know what I'm listening to and I know how to pick that out. But when the average person hears it, they can't necessarily verbalize it all the time, but they know. They're listening to this doctor say, let's just use those people because their lives are less worthy than those who they would sacrifice themselves for in order to develop a vaccine. And when you're told you're less worthy, but oh yeah, come on and be a part of this trial, and you bring with you the history that your ancestors and people have told you through barbershops, beauty salons, barbecues, etc., you bring all of that with you to the table and you don't know who to trust because the authorities, the ones who are supposed to know, are telling you you aren't worth as much as the next person. And so I'm very cognizant that I am not the norm, but I'm also cognizant that I have an opportunity to enter into certain conversations, into certain spaces, and I have to.
That's interesting that you said that, Dr. McCalester, because in my experience, when I kind of like flex my intelligence and try to meet the doctor at the table and really try to engage with the healthcare professionals, I find that they often denigrate my intelligence and tell me, who do you think you are to challenge my intellectual kind of space of treatment, you know, with your lived experience? And I'm like, isn't this supposed to be a two-way street? Like, I have lived experience, you have knowledge, and we both trade, and then we, you know, have a prosperous relationship. They had no concept, no understanding of that. And it's just like, I recently was just in the hospital, and so with sickle cell, we, like, the common denominator of this disease is pain. And so one way that they often tell us that we're not experiencing pain is based off of lab numbers, hemoglobin. And so a lot of the sickle cell research, the little limited research that is out there about sickle cell disease and the limited practitioners that actually treat this disease, right? They have this antiquated understanding of saying whether a sickle cell patient is sick based on his hemoglobin, and they understand it through the lens of one type of sickle cell. And there's about 12 different types of sickle cell, right? And so I have one of the rarer types of sickle cell, so my numbers don't normally follow traditionally what they see as sickle cell SS, the most generalized type of sickle cell. So when I was talking with the practitioner, I was explaining to him that while my pain management plan is adequate for all intents and being, I'm having an issue with like having a reaction to the medicine. And so commonly, if I ask for IV Benadryl, I'll be deemed as a drug seeker. So instead of saying IV Benadryl, I ask for IV antihistamine. And so when I say IV antihistamine, he's like, what? You're using my language against me? Like, you're asking for IV Benadryl. And I'm like, no, actually, there's about 4 other IV antihistamines that's on formulary that can do just as much as IV Benadryl. And so when I mentioned that and started listing off the different medications, he looked at me like, Ruqaijah. And I'm like, whoa, Ruqaijah, that's not my name. Like, and the fact that you just tried to like weaponize my blackness against me, when in reality, Ruqaijahs are usually the smartest ones in the room if you want to talk about it, right? And so he did that. So long story short, I dismissed him. But what I found even more interesting was that they sent in a Black nurse manager to calm me down and tell me that this was not racism that I was experiencing, and just doctors being overworked by, a low budgeted kind of healthcare system or whatever. Because I do live in St. Louis, like a really big metropolitan area, right? And we have situational, disparity all over the place with where our hospitals are organized in the city to begin with, and the amount of practitioners towards these diseases, as I said earlier. And so when she comes in, she's just blaming all, like, maybe he's just overworked on that. And I'm like, do you realize how you've been tokenized to come in here and try to just disarm me as a Black woman? And so if he's making these small mistakes, and we know that medical mistakes are are the third leading cause, like medical errors are the third leading cause of death in people. And then when you desegregate the data and look at race, it's even more astounding, right? So for you to come in here as a Black woman and tell me that this is a small minor, what is a small misstep? What does a big misstep look like? This is my life. Like, it may be a job for you. You can come back after an error. I can't. So, and just the lack of accountability, and just the increasing denigration of community intelligence and lack of transparency in a lot of this academic language, I think is really problematic if we are going to continue to try to persuade Black people to partake in these trials when we are not there politically or like attitudinally yet.
And I think that's a good point. One of the points I was going to mention, what we need to do, that my co-founder of the Institute for Healing, Justice, and Equity, Professor Amber Johnson, who's a associate professor of communication at SLU, focuses on is the need for truth and reconciliation, right? That at this point, there's a long history of medical research that has been exploitive, that hasn't provided us with benefits. I think a great book on that is The Medical Apartheid by Harriet Washington. But that as we continue in the healthcare system, that there are lots of daily affronts and problems that lead to our mistrust. And so if we're thinking about moving forward with vaccines, that there needs to be a point that we're willing to sit down and acknowledge the truth of it. It's not just this one-off Tuskegee, it's during COVID-19, it's lots of problems with the hospital system, with the healthcare system, with healthcare providers. And let me be clear that it's not just across races, right? It's not just between white physicians and Black patients. It can be between Black physicians and Black patients. It could be Black patients to physicians back and not the respect, right? But there is a lot that we need to address. And so just rushing towards vaccines, saying at this point, we don't have the time to actually sit down and acknowledge the harm and begin to heal from it, discuss it, form a common language and a common plan to move forward, I think is imperative at this time. You asked us for sort of short-term and long-term solutions. I think that as you're partnering with people from the community, that truth and reconciliation should be part of it. And I think also a language about what is happening, right? Because from some perspectives, particularly in the US, as we push this market system of healthcare, we often put the burden on the patient, right? Patient-centered care, that you should figure out what you need, that you should be aware of the treatment, you shouldn't overuse, you shouldn't do the moral hazard of insurance, right? Seeking more care than you actually need because you're not paying for it. But when patients come in knowledgeable, when they ask for particular things, we do not recognize that. And so it's a disconnect on what we say we want in the market system, that the patient should be in control and have power, and then we disabuse them of that power. And that often happens to women, and the intersection of race, gender, and poverty. And I do want to just highlight one thing that I saw sort of in the questions about how women and minorities are not participating in medical research. I think it's so important to include transgender and just across the board, because to me, just like race, we often try to box people in terms of gender and don't understand the continuum that is gender, right? In terms of not only just genetics, hormones, and everything. And we are never discussing this, at least at this point. I haven't seen a discussion about that in participation with COVID-19 vaccines. So I just wanted to raise those issues as well, that it has to be all groups of people who are involved. But in order to do that, we need to be clear about the ways that we have erected barriers to prevent them from getting care, and particularly for our transgendered individuals.
So I would love for you guys to speak to actually the first question in the chat box, which is this question about the role of Congress. And I actually want to expand it a little bit to think about like big policy solutions. And so Congress, I think, is the big one. Big one is like, if you're putting together a package tomorrow and you could ask for $1 trillion, what would you put in it? But the other thing that I'll just incorporate into that to give you an even bigger question is I'm very interested in hearing you think about multiple institutions that don't often get discussed. So you're talking about pharmaceutical companies, you're talking about universities. I think those are like, you know, if we're talking about, when we talk about institutions that are involved in health disparities and in racism in healthcare, we don't talk enough about how many huge pillars there are. So the Congress question, I think the policy question on that level is where I'm particularly interested in hearing you go. But I'm also interested in being cognizant of thinking about how about those other mega institutions that we are sort of up against in terms of healthcare and vaccination.
So one thing I think about, particularly in the book I'm working on now, is the connection, the often unexplored or unaddressed connection between the healthcare system and the carceral system. And I don't just mean providing some, you know, suboptimal healthcare for people who are in prison. I mean, what does it look like to come into a hospital and present with symptoms and to be insistent about those symptoms, right? So I have a chapter in my book called In Praise of Difficult Patients, right? So if you listen to Ms. Sumter's account, if you listen to Dr. McCallester's account, right, where you're coming into the hospital space and, you know, being accused of drug seeking, what does that look like if you are accessing public health? Public hospitals, public funded hospitals? What does it look like if you're going to the health department? What does it look like if you are an immigrant and concerned about your immigration status? And who gets called to kind of mediate your care? Or what is the threat operating in the background, even if no one is going to call the police on you or call INS or call some sort of kind of authority who has the ability to arrest you or otherwise make your life miserable. And I think, you know, we've spent a lot of the hour talking about trust, but I think that that's just one more manifestation of how mistrust is built into these healthcare systems, right? And the ways that a lot of these systems interact in ways that aren't always immediately obvious. I mean, you know, if you have a private physician, then you're less likely to have certain kinds of public involvement in the decisions that you make between you and your healthcare provider. I mean, Dorothy Roberts has written on this, particularly around pregnant women who use drugs and how Black women are disproportionately find themselves arrested immediately after giving birth, even though the usage rates are similar. So, you know, who has the authority to make these decisions, and the ways that race and kind of perceptions of Black people as criminal, particularly when it comes to drug seeking and drug using, when there's discretion to make choices, I think that, you know, we have to talk about the role that the carceral system plays. And I mean that broadly speaking, like calling police or INS or sheriffs or whomever.
And I would jump in on the question. Oh, I'm sorry. I didn't mean to cut you off. I will be really quick. I'll be really quick. So in terms of Congress, I think for me, Congress jumping in with what? Right now, I need Congress to jump in to say that OSHA is actually going to go out and protect some of these essential workers. I need Congress to actually say that we're going to provide paid sick leave, death benefits, treatment. I mean, I'm so happy that in the CARES Act, they said that testing was going to be free, but people need free treatment. And we're only starting willing to focus on the long-term health impacts, right? And so, you know, you see the cost of it for just getting over the initial COVID infection, but what happens when there's a long-term disability? So for me, how you build trust is not by saying to people, hey, we really want you to be in these vaccine trials, is we are going to support you, value you, and then we also want to support you by doing these vaccine trials.
I was only going to add, in terms of policy, I think the ideological split that we have right now makes it sort of just difficult to even sort of conceptualize how do you move forward. I think that there was a moment where, when COVID began, and it wasn't necessarily affecting Black communities, brown communities as much, the response was a little different. And once we saw sort of that shift in terms of who was being affected the most, you saw the governmental sort of pull back from being sort of in the forefront talking about the disease. And so that split in, should we provide people healthcare, that split in, you know, do we believe that this is the flu or the common cold, or are you using some sort of farce that you're putting up there when maybe you are more serious about it, but you're saying it's not that serious for whatever political gain. But that sort of divide, I think, is one that, of course, has caused numerous deaths, but I think that it'll be even more detrimental to Black communities, because of the fact that if those who represent certain constituents to demographics believe that this is simply attacking certain groups at a higher rate, and that it's not affecting them nearly as much, it's very simple for them to sit back on their laurels and not respond. It's very easy for them to not want to push through another packet, another bill that could possibly increase money for all the things that have been mentioned here. And so I'm not hopeful. I shouldn't say that. I'm not hopeful that we will be able to move beyond this with the current, you know, balance that we have in Congress. I'm just not.
To elaborate from my patient experience perspective about how Congress impacts clinical trials, me particularly, I will say one of the reasons why I am hesitant to participate is how we think about who gains from this research, right? And so when they create patents that now get placed on these medications, or even if we look at it from a historical perspective of looking at the HeLa cells, Henrietta Lacks' family never received any type of compensation, and it's even gone as far to accuse Rebecca Skloot, the scientific researcher who was now placed into this community. She's even been accused of not depicting the family correctly or sharing funds with the family. So when we talk about bringing outsiders into these communities, and then the knowledge that's gained from this research then becomes profitable, and those profits are not returned to these communities, Congress has a lot to do with that. And that's why I thought it was important to bring up the political determinants of healthcare, because the political action or inaction of the United States tends to fuel the healthcare disparities and the healthcare gap that we see within different communities. So yeah, Congress plays a huge part. I don't know specifically like the ins and outs of policy, but I know specifically looking at patent usage, because with the sickle cell community, they just recently had two new drugs come out. And so they were heavily trying to recruit on the market, trying to get us to participate. And so I know for me, that was one of my big things about who owned the patent, and will these drugs now be available to the sickle cell patient population, seeing as we are, we have high rates of, or disproportionate rates of low income and Medicaid in our community. So can we even afford these drugs once you do the research? And so they have made the drugs affordable somewhat, but we've had to go to DERG meetings with the Medicaid and try to really argue our points on why we don't have to go through all of these other steps with different medications. So it's a big entanglement of trying to address that political system, but one way was through DERG. herbs and Medicaid means in trying to get medication being affordable for us once it is brought to market. So with One Day Sooner, the information you guys glean from these research trials, like, will it be equitable, like distributed, like, and if people refuse to take the vaccine, will that be honored in itself?
Reminds me of hydrochloroquine, Plaquenil. I needed to survive. I need it daily. And as a result of what has been happening, it is adversely affecting women of color, but women, because women tend to suffer from lupus at higher rates than men, of course.
Oh, you went out. You went out.
Sorry. The politicizing of the drug has real consequence. And so when we're talking about, you know, availability of vaccines and testing and things of that nature, you can look at the lupus community, because the lupus organizations came together to write to say, like, this has to stop because there are real life consequences. Over the summer, I wasn't able to get my full prescriptions because we've had a huge shortage worldwide since last June, on top of what has been happening with the politicization of hydrochloroquine. And so I wonder if some of the rhetoric tied to this particular administration, if and when a vaccine is made available, will the vaccine be subject to that type of politicization? Because it could mean life or death for people. And part of me doesn't feel like this particular administration cares in terms of who dies and or who has access, based off of their actions and based off of what I've experienced as a lupus patient.
Yeah, absolutely. And I think that's why some of Naya's points about transparency are so important. And some of the questions, there have been some questions in the Q&A as well, raising these, and we can't necessarily answer those because these things, it isn't all transparent. The data gets dumped periodically, and it's, you know, often even the questions about will you take a vaccine, that data is pretty, you know, questionable in terms of if you ask, will you get a vaccine tomorrow? No, because it would be improved by the Trump administration on a very short time frame. One thing I did want to highlight is there is a question about what are some strategies to be as anti-racist as possible. And I just want to indicate that I think Professor Yearby already answered that really well when she said that support and value people first. I think that's a really eloquent and really, like, I think that's the answer. It's a complicated, it's an answer that can be hard for some people to face because it's so simple, because it's about, you know, basic empathy and kindness and, you know, seeing people that way rather than saying, okay, how do we, you know, what is the other end goal of this, that, and the other? So I just want to highlight that.
And I wanted to go back to a point, I think you mentioned, Dr. Wilson, about it's sort of what you say versus what you do. Right. And so to me, valuing isn't just, you know, I didn't say it or I didn't do it. Right. To me, it's also about the support you provide. And so I think what has been very interesting to me as people begin to roll out vaccine trials is no thought to the fact that people on these trials need to have access to healthcare, and not just access to healthcare that says, oh, you can get into the doctor, but you have to pay for it yourself, but really access to healthcare, which means that if there are any issues that they're covered. I think going further then is also to understand that sometimes the people participating in the trials are the breadwinners. And so what happens if they are harmed? Because it's not just them, it's their families, it's their children. So just wanting to add on to that, because I think sometimes we say, oh, you know, oh, I didn't mean it, I didn't say it. That's not good enough in this space, that it has to be more material and financial support, especially for the people who are most apt to get it and who are most vulnerable.
And hopefully to build on what Dr. Wilson also started us off with, is just a question of intentions aren't enough. And that when we realize, and I think part of I think it's like the post-civil rights history, is that when we realize that our intentions weren't enough, well, we have to stop and try something else. because it's not enough just to back off and say, well, we gave this a shot. And it seems like we're going to see that with a lot of these clinical trials as well, or I'm afraid we are, when we're seeing these news articles come out saying, oh, they're struggling to have diversity and inclusion. And I'm like, okay, so what's your next strategy? What are we going to do next to make sure that these go?
Absolutely, because if you don't, let's say you don't get the numbers that you want in the challenge trial in terms of from certain demographics, what will you do to make sure that the demographics that aren't represented still get the information, still feel included in the process, because they're stakeholders whether they're participating in the trials or not?
I mean, I would also add to that, right? It's not enough to just throw up your hands and say, oh, people just aren't interested. I guess we just got to go on and no. That is the space where you step back and you say, okay, what is it that we're doing wrong, or that we're not doing enough of, or where are the spaces that we need to do more? That's not the throw up your hands moment. And that's also what I mean when I talk about intentions not being enough. Also, to pick up on what Professor Yearby said, right? There's a big question among some biomedical ethicists of what are our obligations to research subjects once the study is over, right? So with lots of study designs, people might be inclined to take care of someone while they're in the study, but then it's just, okay, go with God, good luck, hope everything works out for you. And certainly if you're thinking about communities that have a history of being marginalized, have a history of being exploited, that just kind of furthers the sensibility of exploitation. Oh, these people didn't care anything about me. And I don't mean care in some kind of deep way like you care about your family, but I mean just in a kind of sense of respect, basic respect for humanity. Oh, these people literally did just see me as a subject to exploit. And so when, Professor Yearby talks about care, right, we also have to think about what does follow-up care look like once the study is over. And that's also about being deeply anti-racist.
And asking subjects what care looks like to them. Mm-hmm. And not just being in the study and then determining for them, because they should have a say in terms of if I'm going to make this very, risky decision to be a part of this challenge trial, I ought to be a person that sits at the table and at some point in the process have my voice heard as to what I might need following my participation.
But see, part of that, you have to assume that folks are competent. And one way that racism manifests in kind of interpersonal spaces is just assuming that folks aren't competent. Assuming that if I tell you my knee hurts, that you're going to decide whether my knee actually hurts and not listen to, right, as Ms. Sumter has talked about, right, symptom reports and that kind of thing, right? I know the lifestyle that I live. I can answer basic fundamental questions about who I am and what I do day to day. I don't need, right. One way is that racial dynamics sometimes play out is assuming that Black people are stupid. And it happens in really interesting ways. Like I even had a white graduate student tell me that I read very well once. And I was like, did you think they found me off the sidewalk to teach philosophy? Like these kind of little, I think they call them microaggressions these days, right? Folks can be microaggressive without intending to, and maybe someone will never respond to you and tell you that you are out of pocket, and then they just wander off. So if you find yourself in an organization and you're like, the Black people just all leave after about 6 months, guess this just isn't a good fit. No. That's an opportunity for you to do some checking.
And then that has to do with cultural literacy too. Maybe you're communicating with people and it's not that they don't comprehend or they don't have the cognitive ability to comprehend. It's that maybe the ways in which they communicate, that you need to be cognizant as a researcher to say, how best does this person, how do I say this? How can I best communicate with this person, culturally speaking, and without necessarily being offensive? Does that make sense?
And I think that's why it's so important about the partnering with the community groups, right? For two reasons. One, because then that allows the researcher not to have to be an expert in every community, and the understanding that every community is not monolithic, right? And so hearing the needs of particular individuals from that community, being open to it, being open to change, but also then taking in consideration, which I think it definitely falls under the justice principle, about that we think about individual participants when we talk about autonomy, beneficence, non-malfeasance, but with justice, it is about a community, right? And community can mean so many different things. And so just to ensure that if you're talking to an African-American, transgender, disabled person, right, that you get all that they need, right? All that they need in the care, all that they need in the support. And that I don't want to hold researchers responsible for, but what I want to hold them responsible for is to ensure that they have people within the study who can speak to that. Right? That it's not just sort of a token person, let's go find this great match, but that it's really partnering with the community groups that have a history and will be there and be supportive to ensure that they're in the research design, that they're through giving out the vaccine and continuing on. Because I think oftentimes we think that it's just a one-off, right? It's just the vaccine, but it's not. Right? There are multiple points where people need to participate and need to participate in the vaccine trials, drug trials, or whatever. So why not build a relationship that is symbiotic and not exploitative?
I really like this point that we, especially vaccines, we think of as a one-off. I think that's I think that crystallizes something for me that I've been thinking about for a while, is why vaccination seems different from other kinds of medical care when it shouldn't be. It doesn't need to be. So I won't take the last word. I'll give you guys all a chance to share your final thoughts, because we are just about at time. Before you do that, I want to thank you all for participating. It's been really, really illuminating to hear your thoughts and to help us continue this conversation around and moving it into this, these vaccine issues that are so much of that are certainly one of the next things that we're staring down. And I hope that conversation can happen in more productive ways than some conversations have happened around COVID-19 so far. So anybody who wants to share last thoughts, please do.
Well, one thing I'll say is that, I'm just happy to have participated in this conversation. But one thing that I hope at least that the audience has gained, and also my fellow panelists, I think we've tried to show in different ways, is that, vaccine trials aren't just about vaccine trials, right? That they don't exist in this kind of hypothetical vacuum where you can kind of just think about the vaccine and the data and the research. There are people and their histories and their institutions that all have to come into play and be taken seriously and considered if we're going to do this right, if we're going to do this in a way that is ethically defensible.
And that there's a reckoning, as you have alluded to, that has to happen in order for, I don't want to say the relationship, but it is the relationship between Black communities and the health field and research, and honestly, a lot of institutions that have for a long time made decisions about how Black people would live and move and function without them being included in the decision process. And so for me, this conversation hasn't necessarily been concentrated on the actual challenge trials itself, but literally sort of talking about what are the things that prevent us, from being able to be a major part, a true stakeholder within this type of research, and what are the barriers that we're facing in just simply interacting with the medical community at all. And so I see that the conversations about sickle cell and about lupus, of course, they're not vaccine related, but they give you an indication of, we don't have a choice when it comes to interacting with the medical community. For me, yes, with studies, but if I have a flare, I have to go to the hospital. I have to go to numerous specialists. And so that's something that I can't avoid. But for a lot of people, when you're talking about trial, vaccines, that's a decision that you have to make that isn't necessarily something for you in terms of being life or death. And so kind of talking about the regular interactions that Black people, women of color, et cetera, are having on just a regular basis with the medical community, I think can open up and illuminate some of the areas that need to be addressed to get more people to participate in challenge trials overall. Thank you.
Go ahead.
I think my last words would be to push African Americans, and myself included, to actually participate in these clinical trials, because the Black Panthers best said it in their health activism platform. We cannot ask for medicines without participating in these clinical trials. So it's a catch-22. To be able to leverage our position in the system, we have to actually participate in the system. So I do want to push us as a community to participate in these clinical trials, but also push the academic community, the scientific community, to truly right the wrongs that they've done historically to us. If we are to, really look at undoing or fixing that chasm between these two communities. So that's what I like my last words to be.
And I would just briefly add that unfortunately, COVID-19 has offered us an opportunity to be stuck at home and to have a moment to think. And what I would hope is that we would use that moment to be able to humble ourselves, to begin to acknowledge the wrongs that have happened, not just historically, but that continue to happen, and to be willing to apologize and work to get better. I think that's the only way that we can move forward. And I know we're talking about vaccines, but I think just in general, that this is a space where we are all impacted, that we could all die, that we are all harmed in some way. And so this is an opportunity for us to say, let's work together, let's partner to make it better. And the first step could be in the COVID-19 vaccine trials, but it has to be bigger. So I just hope that this will be a time that we'll be humble and say, let's work together, let's partner to make it better. So.
Yeah, thank you. I think that's a great way to leave it with what we have to do next. So thank you all to the panelists for participating and for everyone for attending as well. As I said, we'll be doing more of these, so stay attuned to One Day Sooner lists or emails and social media and all that.
Thank you.
Thank you.